Please let me know. I can tell you. Don't have the feeling, just let it show. I can tell you. A feeling so deep that comes within. I can tell you. What kind of love am I in? Ooh, I can tell you how I feel about you night and day. About you.
We're giving all the resident certificates.
Right.
This is the third Pan American, but we've had three Peru, Russia, one in Russia, one in. So I think it's some of Were you there? Joe ran that meeting.
Yeah. Jesus, we really will let anybody in. Anyone. You're not holding anyone at the door.
He really didn't say that.
Thank you very much. Okay, good. You got enough bandwidth, huh?
Okay, with that, doctor, which,
Vinagre, vinagre for your fix. Yeah.
Okay, well, the Wi-Fi works. There's all these little questions like that. It'll be okay. Yeah. We're in a big city too. It's not like this is steamboat. Going Western Trauma.
yeah, just made hotel.
Okay. Sir?
Oh, sir. Peter?
How's it going?
We really scraping them hard and getting some splinters. What's he yelling about?
Propofol is what you're supposed to.
Oh, yeah, yeah. That's
Don't do that again.
No, yeah, I'm proud of you for doing it.
It was,
But don't do it again.
I did it and I was like, I'm not here about that. But I will tell you.
Good morning.
Hey, good to see
Yeah,
you.
Yes.
Oh, yeah. We charge you
Good
for
to see you.
Well, hey, I'm sorry, good morning. You got your EVTM tie on also?
Yeah, well, I'm trying.
Hey, it's,
How's it going?
it's good. Good to see you.
Yeah.
Morning.
They all look great.
We're not participating anymore.
Always bearing.
Been an interesting bunch of years.
My head down.
All of us. Pushing forward. I gotta tell you though, I'm just thinking this is the first session. I kind of have to invite you almost a decade ago. You're showing me that.
That's rough.
Man, with that one. Now I get it. And Health and Hospitals is now doing it in small areas. And guess who's leading our team? Anna Laveris. So, shot trauma training fellow. And it's like, if you would have told me the Health and Hospitals, no, so it's Bellevue and Jacoby.
Yes. They quick fit around the health and hospital.
Yeah. Although, the other places, I'm the lead, the chief trauma surgeon for the system. And we're coming along.
But this is
Next level.
yeah.
Yes. The key was to get a contract into the perfusion. And then people, people are trained.
I've told people, especially
Yes.
The other thing, the first thing that really,
okay, I did not know you had Jim O'Connor.
just do,
But again, you don't know my name.
Yeah.
James O'Connor.
You got two short.
Yep. And it is multi, service, the cardiologist and the vascular surgeon sort of helping.
You got some internet problems.
Really, it's animal.
Then you get into your ASAP.
I said, I'm just. What happened is because we got one patient on it now, who's a trauma patient. This patient, because, we couldn't get on the phone fast enough for the exclusion criteria,
You put them on,
whatever, APRP. Yes. And we just attributed it to something else.
Very.
It's for 6 minutes.
Sorry, what was your name?
I was just saying, Tom, my little, health
Starting in 2 minutes and then it'll start flashing.
Maybe.
the main driver.
Yeah, and they should know.
It's a 5-minute discussion, 6
And
minutes.
I was here.
So it's 11 minutes.
It's 11 minutes,
It's
all
6
right.
plus 5.
Now I understand. All it took was a small pandemic to teach me. Yeah, you remember I was talking to you during that period.
Okay.
Yeah.
This here, I'll talk to Richie. I'll reach your brother.
Okay,
I bet you saved a bunch.
Yeah.
Still.
Yeah, very good.
Still. Yes, they were. We saved famously one nurse. I got the monitor, I closed the program down because all the viruses in the sick room. They opened up for me and she.
You see what I did? I never was going to pack up.
So you go back to the trenches for a few days?
Yeah. Like, things are good. Well, sometimes it's a good problem to have. What's so great? I like to say
Sure.
gloves. Meaning, these kids are so, they're so bright-eyed and bushy. They come in and this morning before, and I do this, transnet, so blah, 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 and I'm like, and they're so well trained and they just, and they have a family life coming out. And they love it. We turned it down too. Getting them to like Cowley. If I had enough APPs, I would do it. They don't really care about products. They never did. I know. So, and I was going, you know, on she tried to sort of help me off. Bill, sure. I'd like to say finishing school. She came back and she was forward on that.
Sponsors or supporting the meeting.
I mean, I haven't seen her, but because I work there, they but not.
And to remember that it's
Narrator dialog. Windows. Windows. No button. All. Exiting narrator.
Well, welcome to the third Pan American meeting, EVTM. I appreciate everyone coming from such far distances to support the meeting. And I just want to say that this meeting was developed after the Orebro meeting last December, and it was overwhelmingly supportive and supported by the faculty who agreed to come and speak at this meeting. And Rishi and Dr. Scalia have done a great job supporting us to put on a really wonderful program of 68 talks and 16 sessions in rapid format. I'd like to thank our sponsors. Without them, there's no way that we could have a meeting this elegant in this great city. I'm proud to be part of the organizing committee because this is my hometown, so it means a lot to me to have this meeting here and supported by the Shock Trauma Center. I want to remind everybody that it's going to get a little cold tonight, and the banquet is at the World Trade Center, so it's about a 10 to 15-minute brisk walk down Pratt Street. It's the tallest building on the Inner Harbor. It's on the 21st floor. If you haven't reserved a banquet ticket, let Lotta know at the registration desk so that she can get you on there, because there is a security check at the reception desk as you walk into the building. The dinner banquet's at 1900, and it's going to be great. So we're going to kick off our first session on ECMO, and Jim Manning and Deb Stein are moderating, but first, a few remarks by our host, Dr. Scalia.
Good morning. I'll take 90 seconds tops just to say welcome to those not from Baltimore. Welcome to Baltimore. For those not from the Shock Trauma Center, welcome to the Shock Trauma Center. It's been a pleasure to be able to be the host for this year's meeting. When Tal called and said, "Would you guys do it?" I said, "Let me think." Oh yeah, we'd be delighted to. And Rishi and Chuck have been the driving force behind this. Looking very much forward. Great to see old friends. Great to make some new ones. The next couple of days will be bang, bang, bang. So here we go.
Sure. Great.
Good morning, everybody.
Good morning.
Is that working?
Yep. Are we working? If not, we're loud enough. Guarantee Dr. Manning and I can take care of it. Good morning. It is an absolute pleasure this morning to welcome my dear friend Lena Napolitano from University of Michigan up to talk to us about awake ECMO or traditional. Good morning. Thank you.
Good morning, everyone. Great to be here back in Baltimore. Nice to be here in person since COVID. I'm still thinking about COVID. So I'm going to go briefly through what we know so far, not a whole lot, and we'll have some discussion. The awake ECMO definitions here are two that you'll see in the literature. On the left there, you'll see never intubated before ECMO, so just goes on ECMO, usually with just conscious sedation. On the right, early extubation. They're intubated for ARDS and hypoxemia. They have early extubation after initiation of ECMO. They're on heated high flow or non-invasive or conventional, but then they go to either early extubation or early trach, and usually with some algorithm. So let's first look at never intubated. Here, this is standard of care for our bridge to lung transplant patients with ILD. No question, it improves mobility, it improves early ambulation. But what about in the acute situation? So we began to see in COVID calls coming to us for awake ECMO, and this is what they were asking. You know, could they transfer a patient to us on 100% or on heated high flow and get them cannulated for ECMO and never intubated? So here's one of them from Paris. This is a case report, 57-year-old. You can see there are 2 ECMO cannula position, had a prolonged run on ECMO, but subsequently recovered. X-rays look great over time, markedly improve, and fully recovers. This is one from San Antonio, Texas. Same, case series, case reports. Young guy again, 57-year-old, had about 57-day ECMO run, fully recovered, never intubated, unheated high flow, conventional oxygen, and then nasal cannula. And then what we see are a couple of case series. So this case series here is 7 COVID ARDS patients from Pisa, Italy, awake, non-intubated. 1 patient after ECMO cannulation under conscious sedation did require intubation due to worsening respiratory status. They decided to put these patients on ECMO and not intubate them because they all had high risk for pneumothoraces. None of these patients had pneumothoraces. 2 patients died of MOF. No early mobilization or early mobility or early ambulation associated with this protocol. And then lastly here, a German tertiary care study. There were 4 German ICUs that these patients were enrolled from. They took 18 patients that had, quote, awake ECMO, never intubated, again, extubated, fully awake. The ones that stayed extubated, of which there were 4, had 100% survival. But importantly, in the middle there, you'll see that 14 of the 18 had delayed intubation, and they had a very poor survival with late intubation, 36% survival. And then the patients who had mechanical ventilation on the right there had overall a 50% survival. So that's what we know about, quote, awake ECMO, never intubated. I would suggest we use this very cautiously in very selective patient populations. In our entire system for COVID, we did 1 patient like this. The other, I think, is much more mainstream, early extubation. You intubate them for ARDS, they develop worsening hypoxemia, you go on to cannulate, and then you move towards early extubation or trach. Everybody knows about the Chicago protocol, the Russian Advocate Christ protocol. Their overall survival is 85%. We haven't seen those rates a lot. This protocol, I think, is really important for everybody to carefully look through. They've published their protocol. They actually publish exactly what happens to all of these patients. They've recently reported, in addition to their extended report of 150 patients, this report of both COVID ARDS and non-COVID ARDS patients using the same protocol. All of these patients get a Protect Duo. Within usually 5 to 7 days, they get either extubated or trached. Very few trachs. Most of these patients are extubated. You can see ECMO cannulation to extubation, 6 days. Another report here of 42 COVID ARDS patients with early trach in 48 hours after cannulation. This has been a strategy we've employed a lot. Similarly, had a very high survival rate, 74% for awake with early trach, and 37%, as you see there, for the traditional strategy of sedated for quite a period of time. And just to remind everybody that the Eolia trial had a 65% survival rate. So these survival rates are much higher. And then as we see the first case series from the ELSA registry for early COVID ARDS, remember the survival rate was about the same there, 66%. We think part of the reason why these patients do so well is they get less ventilator-associated pneumonia. This is a report of the very high rate of VAP, 86%, that occurs in COVID ARDS patients, and it recurs in 70% of those patients with the same pathogen. So the real question here is awake ECMO prior to or after intubation. There are a couple of centers that are actually doing some single center studies. We have taken the approach, as we do in our peripartum patients, that they get intubated first. We get to early extubation or trach. Here's 2 of our peripartum patients, both 3-month runs on ECMO, both did well with trach. And finally, there are pros and cons to this approach. I think we all have established that it's the right thing to do. You need to remember that when they're spontaneously breathing, they can chug a little bit more because actually their IVC decreases in size when they breathe. And then lastly here, there are 2 reports of awake ECMO for refractory cardiogenic shock, markedly reduced both 60-day and 1-year mortality rates. So in my mind, selective use of ECMO, first strategy, we don't really do that, and then routine use of early extubation, early awake.
Thank you.
Yeah.
Obviously, take some questions from the floor if people want to come up to the microphone. I'll start.
Yeah.
Something I've always wondered For people with respiratory failure, what's more morbid, mechanical ventilation or ECMO?
I think mechanical ventilation is more morbid because of the VAP rate. I think if you manage ECMO really well, we use low anticoagulation, the move towards, not high PTTs, has less bleeding, less blood transfusion. And I think if you're using more dual lumen cannula, it's really less morbid.
So why not more popular, just put people on ECMO rather than intubate everybody?
Yeah, I think partly the issue again is patients are nervous. Like I said, we used it once. I was actually just telling this story. We had a nurse from Detroit who was an ICU nurse who knew exactly everything we were doing, who could tolerate it. But many patients just can't tolerate it. In that study where 14 patients of the 18 got intubated early after the awake ECMO, no intubation, many of those were for anxiety. Just put the tube in.
Right.
Yeah.
Thanks.
Luke Neff, Wake Forest University. Thank you. It's a great talk. We do, as a pediatric surgeon, actually, we do a lot of the adult respiratory ECMO, and had a recent case where a surgeon needed to go on ECMO, and I found that run to be much easier for some of the issues you just mentioned in terms of their awareness. And so 2 questions. One is, bicable cannulation is great. It facilitates a lot of mobility. A lot of people are saying it doesn't matter. Even if you've got cannulas in the groin, just do it. You mentioned for these patients that are spontaneously breathing, a lot of the issues with IVC collapse, and just wondering if that is an issue, pointing it out, like maybe you need that extra drainage cannula to prevent a lot of that passivation, a lot of that chatter. And then the second question is, I always struggle with this. I push for early trach for all my patients because I figure if we're going to go to bival or cut heparin for a while, that I want that circuit while it's still fresh to, it can take a little bit of a joke. And just curious your thoughts about how early is early.
Yeah, I'm an early trach person, literally within 2 to 5 days for the same reason. And we fry everything with the Bovie. We do sort of a modified perk approach and buzz everything with the Bovie. I will get to the issue of IVC collapse and chugging with spontaneous ventilation. That occurs whether you have a trach in or not, right? Because with a trach in, we try to get them off the ventilator as well. So we just keep them volume up a little bit more. We don't diurese them as much. We really haven't had to put additional cannulas in. And if we've done an emergent 2 cannula, 2-site approach, we really try to transition to a single dual lumen cannula as quickly as possible.
Do you have any questions?
Nothing from me.
I have
Yeah,
one more. I have
essentially.
2 more actually. I'm going to pick her brain while she's up here. We've had issues with the dual lumen cannulas with our larger, more muscular, younger, healthier patients, just because you can't get their flow rates up high enough to oxygenate them effectively when their lungs are completely non-functional. Have you had that issue? And is there any way that we can manage that with the single cannula?
Yeah, so we always try to put in the largest 31 or 32 French. I think that's really important. We really haven't had that trouble, and I would say we're uniformly not putting in a second cannula. I think we keep them volume up.
Okay.
Is really what we do. Yeah.
Yep. And then my last question is there somebody who would come in to your hospital today that you would choose to put on ECMO rather than mechanical ventilation? Is there a patient population that kind of pops into your head as the ideal candidate for this?
Yeah, young, healthy, not anxious. I think so.
Great. Thank you so much.
Okay, so we're moving along on time. So our next speaker is friend and colleague, Dr. Bill Teeter, who's going to talk about arteriovenous ECMO for trauma, who, when, and what to think about.
Good morning, everyone. My name is William Teeter. I'm one of the trauma intensivists at University of Maryland Shock Trauma. Thank you for the opportunity to come speak to you today. I have a similar talk to Dr. Napolitano in that we're talking about VA ECMO in the trauma population. And I'll talk about what little we know, and then I want to get to a discussion because there's lots of expertise in the room that I think we could have a good discussion about this. So for those in the room that I have no disclosures, for those in the room that are not aware of what ECMO is, I'll go through it quickly. I wanted to point out this article, which I found. This is a recommendation from a panel from the AAST. It's an interesting review of the literature. There's not much in the way of VA ECMO recommendations, and we'll talk about kind of each segment that they go through in my talk. But for those who are not aware of what VA ECMO is, because I know we have some trainees and some other folks here in the audience, this is a adjunct that we use for people who have severe respiratory and cardiac dysfunction. So the difference between VV, which you'll hear about in just a second from Dr. O'Connor, is we are supporting the heart as well. So we take blood from the venous side, put it back into the arterial side. The criteria are better studied in the non-traumatic population. There's really not that much data out there. The criteria are varied, and end organ dysfunction and various hemodynamic parameters are kind of what we use as far as who do we select for this. Now, I will make the distinction of VA ECMO for trauma and VA ECMO in trauma, and I'll tell you what I mean by that in just a minute. So this is a slide from a paper from ELSO talking about the contraindications for VA ECMO. I wanted to point out two things specifically. These things all apply, I would think, to the trauma population as well. Unfortunately, we do not have sometimes the replete information that we do on some of our non-trauma patients when we're putting them on VA ECMO. So these are all things that we should be considering when we're looking at this for VA ECMO and trauma. So the criteria for trauma, as I said, poorly studied. We often have to weigh VV versus VA without sufficient information, especially in the acute period for trauma patients. The etiology of cardiac dysfunction is important. Exsanguination, hypoxia, direct cardiac trauma all have different profiles when you're selecting VA ECMO as a treatment for them, and different complications. AAST, from that position paper, they recommend a case-by-case approach in high volume centers. So when do we do VA ECMO? Injury pattern in trauma, which drives early consideration of VA, is of likely a very profound severity. Another way of saying this is people who require VA because of their traumatic injury, probably not the best candidates. Cardiovascular collapse due to RV failure, also a possibility in the early selection of VA ECMO for trauma patients. All of the indications and the timing is poorly studied, specifically in VA for trauma. ECPR, there are reports out there, survival of 25%, very poor quality of evidence. Decision-making, as I said before, is fraught in the setting for need of an immediate decision for VA ECMO. So these are people who come in either on arrival or shortly thereafter. They are in extremis and they're in almost cardiovascular collapse or cardiovascular collapse. Sometimes you have to make that decision without all the information. So what to think about? Early consideration, like I said, is fraught when you don't really know what you're dealing with. It is possible to run VA without anticoagulation, but that increases the circuit life and thrombotic complications. So if you have a TBI patient in a blunt injury, you have to think about, can I heparinize this patient? Do I need to heparinize this patient because of the circuit, or can I run them off of anticoagulation? PE is interesting. It's probably one of the few things that I would recommend that we consider in these folks. We have shown in our data that we have actually seen DVTs and PEs earlier than what's published in the non-trauma literature, and sometimes up to 3 days. I think Dr. Menaker's paper said that it was around 3 days that we're seeing this. So RV collapse in the trauma population is definitely something that you need to think about, and a possible etiology that we would use VA ECMO for. So as a summary, VA ECMO in trauma is poorly studied. There's limited definitive conclusions on efficacy. The injury pattern and severity needs to be weighed against heparinization. What is their TBI? What is their solid organ injury? What is the plus minus of heparinizing the patient? And VA and near cardiovascular collapse on presentation may possibly have some benefits, but it's likely too risky given often poor information for adequate decision making. And what I would summarize it as, decisions take time when there is none. Okay. All right. Thank you very much.
Thank you.
Thank you. So, questions? Go ahead.
Good morning, Shel Tepperman from New York. Hi, everybody. It's good to see everybody in person. There's one population, Dr. Teeter, as you were speaking, I was thinking about that. I have some moral injury to have lost over the years. Young people that I've had to do an emergency pneumonectomy on, and then you watch their RV balloon up, and maybe you get them to the ICU, but they just die. ECMO, VA ECMO, maybe?
I think in that population, yeah, if you have a young, healthy person with a trauma pneumonectomy, Dr. O'Connor will talk about that specifically in his talk next for VV. But I think for VA, that's probably a population that we would consider. I'm not sure that we've done it recently. I don't think so. I can't remember one off the top of my head, but I think it's in that young, healthy trauma patient. Absolutely.
So Bill, I accept that in these really complex patients, it's difficult to come up with a clear algorithm or, some notion of who are you going to choose to put on, VA ECMO for this. Is there a patient profile or patient profiles that you think lend themselves to VA ECMO particularly, or specifically do not?
Well, I would say that that question is probably answered by what is the timing that you're talking about. The guy who comes in who's blunt injury and you need to decide right now, are you going to do VA ECMO or do you have a day or two? The example you were sharing with me earlier is, a young patient who comes in, has a horrible injury, gets a thoracotomy, gets cross clamped, but survives to then have complications and then survives to have cardiovascular collapse. In an otherwise young, healthy trauma patient, I think that's what I would go for. I would be very wary about pulling this out of the armamentarium for an early injury. So in the TRU, in our experience, they just don't do well. Yes, sir.
Moore, Denver, very nice. My question is, what's the ethics of implementing VA ECMO for the purpose of retrieving organs? So specifically in blunt trauma, oftentimes we're in the operating room and they're failing to respond, but we have no idea if they have a head injury. They typically have a coagulopathy. Neurosurgeons won't bolt them. So what is the ethics of that? So you're going to the operating room and you assume they have a head injury and now they're not responding. Do you put people on ECMO for the purpose of retrieving organs?
I would say in a word, no. That is, for that reason, no, but it is definitely a consideration.
I'll actually tag off that question because I find that fascinating. I thought you were going to ask a different question, which is what happens when you put somebody on VA ECMO and they just stay on and you can't get them off and you can't, we have all this technology now, CRT and Mars and ECMO. What do we do with those patients where they are too sick to live, but we're keeping them alive? How do you manage those patients?
Well, I think that's probably a systematic approach that you have to talk about beforehand. Talking about it in the heat of the moment is just so difficult, especially when you're facing the family, you're facing a young trauma patient. But, we were talking about this as a group a few weeks ago, is when do you say enough is enough? And I think that's got to be a decision that's center by center, state by state, society by society. And what are the resources that you want to expend? And another question that somebody asked, which I think is particularly apt, is keeping that young, healthy trauma patient on who never comes off. From a societal perspective, how much insulin can you buy? How much prenatal care can you buy for that millions of dollars? I don't have a good answer for that. I think that's something that has to be multidisciplinary.
Good morning. That was a very nice talk, Teets. So if we're talking about ECMO for trauma, do you think that equal attention should be given to consideration of LVAD and RVAD devices in trauma, like the Protect Duo, the Impella, when an oxygenator is not needed?
Well, I think, again, to sound like a broken record, if you have a patient who would otherwise meet criteria for those therapies and a young, healthy trauma patient who's recovered, has neurologic status, doesn't have multi-system organ failure, good societal support, absolutely, I would consider it. You're very well dressed today.
I have one more question for you, Bill. In the trauma patient, one of the things that we often are faced with is the issue of Harlequin syndrome. Could you just address that really briefly?
Yeah, so Harlequin syndrome, or differential hypoxia, for those in the audience who are not aware, is the problem with VA ECMO, especially in the trauma population or this young, healthy trauma patient, is a lot of times their cardiac function is recoverable and reversible over a few days. So we will put them on, their heart recovers, and then it starts pumping. And it is going through the arch in the proximal arch, and then the VA ECMO circuit is trying to pump blood against it. And you'll actually get differential hypoxia. We monitor that with SpO2 monitors on each arm. So as the hypoxia goes up the brachiocephalic, you can test it on either an ABG or an SpO2 in the right upper extremity. And that's our first sign that, hey, we're actually harlequining. We actually had this patient, very problem in a patient in the CCRU yesterday. It was also complicated by a intraatrial septal aneurysm with a rip-roaring PFO. So Harlequin is definitely a problem in this population.
Great.
Thank you very much.
Thank you.
Bill? Next up is a person who probably needs no introduction to this group, but Dr. Jim O'Connor, Professor of Surgery and Chief of Thoracic and Thoracic and Vascular Surgery at the Shock Trauma Center.
Good morning, everybody. Thank you to the program committee for inviting me back. So my discussion today, we're going to go fairly quickly over the use of VV ECMO in trauma, and I think there were some excellent questions that were just asked, and it's not part of my discussion. Maybe we can put it as part of my discussion. It really wasn't in my slides. So I have no disclosures. I was going to do a literature search, which I did, and looked at VV ECMO and trauma. There was 200 and some odd articles. I was going to go over each of those in great detail in 6 minutes. So what is the background here? Well, the early experience with ECMO and trauma was terrible. It was small series. The results were poor, and I would say dismal. And I think a lot of that had to do with you had very rudimentary equipment back then. We're talking 70s, 80s. You had roller pumps, which was kind of now sitting in the Smithsonian because no one uses them anymore. Vascular access tend to be open, not percutaneous. No one really knew what to do with anticoagulation in the trauma patient. Did you do it? Did you not do it? What about those trauma patients that had a concomitant traumatic brain injury? How did that affect the use of ECMO? And also it was expertise. People were learning about this as they were going. The experience that we learned, I think, in the trauma world, we took from our colleagues that did ARDS and ECMO and ARDS, whether it was the initial stuff with H1N1, certainly with the Caesar trial, and more recently with COVID. I think we've all learned a ton. Recently, there's been a push to do more ECMO in the trauma patient with improved survival. So to try to aggregate the trauma literature, what do we know? Just to touch on what Dr. Teeter said, VA ECMO, very rarely done. VV ECMO is what we're going to do for trauma more often than not. Those patients tend to have blunt injury, although not always. They tend to have extremely high ISS. And then what are the strategies that you want for anticoagulation? And we'll touch on that a little bit. There's varying times to cannulation. Early cannulation, do you wait as kind of a last-ditch effort? Probably a bad strategy. And then why do people die when they're cannulated, after they're cannulated and they're on? Well, they die in multi-system failure. They have neurologic insults. They die from extended periods of shock or from hemorrhage. Predictors, and again, I put in question mark there because the literature is a little bit soft on this, but certainly higher ISS, need for renal replacement therapy, no surprise. Late initiation. The longer you wait to put somebody on who has a traumatic injury and goes on VV ECMO, the higher the mortality. And when they looked at studies that said that those patients who had a traumatic injury were vented versus those that went on ECMO and were vented, those folks who tended to be vented did worse. Again, very small series, not great science. So I look at the indications here for a VV ECMO in kind of two different ways. One is conventional, those patients that have really profound refractory problems with respiratory distress, ARDS, pneumonia, the typical. How about those folks that have a post-traumatic pneumonectomy? I'd like to touch on that, and also a damage control strategy. So anticoagulation, I think we figured out lower anticoagulation, PTTs 45, 55. You can do that. You can run them at higher flows. You can run people off anticoagulation, running the flows at generally 4+ liters. TBI is safe with or without anticoagulation. Those patients that have a cervical injury, you may have to do biafemoral cannulation. It's hard sometimes to get an IJ cannula in. And we now have heparin-bonded tubings. We have, you give patients a bolus of heparin at the time of anticoagulation. Last thing you want is the cannula to clot. That's a catastrophic problem. Here's a patient that is kind of a typical indication. This is a patient who had severe aspiration following a gunshot wound. You can see X-ray at 2 hours, X-ray at 4 hours. In spite of maximal ventilatory support, not getting any better. It goes on ECMO, short run, 9 days, does fine. How about traumatic pneumonectomy? What do you die from? You die from either hemorrhage in the operating room or acute right heart failure, either in the OR or very quickly. So to do something to unload the heart, would a right heart assist be a nice idea? Sure, try to do that in a patient that's that sick. Not so easy, but certainly VV ECMO has a role, obviously with inotropic support and other things as well. The other thing I want to just mention, I think we kind of underuse VV ECMO as a damage control strategy. And this is a patient, young lady who was ejected, came in hypotensive, tachycardic, acidotic, hypercarbic, on epinephrine, trying to manage her ventilatory status in the resuscitation bay without success. That's her CT scan, and that's a bronchoscopy. That's her left lower lobe bronchus. Put her on ECMO, corrected her physiology, took her to the operating room. Now she's completely resuscitated on low epi doses, did a left lower lobectomy, muscle buttress, decannulated day 3. So I think the survival now with VV ECMO and trauma is greater than 70% because I think we're just so much better at it. We have better technology. We have better expertise. We know a lot more now about how to manage anticoagulation in these patients. It's a safe strategy in patients that have TBI. There are conventional indications, and I think we need to think about it as part of a damage control strategy. So thank you very much. Appreciate it.
I was going to say, would you like to expand some of the questions from the previous session that were sort of touched on VV ECMO? Would you like to expand on a couple of those points?
Yeah, I think one of the questions came up. I think it was Rishi who asked about other technologies, putting an Impella in and other things for patients. I think that is a technology, certainly, for people in heart failure, especially end-stage heart failure. The Impella is a really great tool. Not so easy to do. Requires a lot of expertise to run that thing. They can be anticoagulated just with a heparin purge. You don't need to have them systemically heparinized. In terms of more mechanical devices, mechanical heart device, left heart or right heart assist, I think that may just be a bridge too far. Plus, all of that is going to be centrally implanted. The Impella you can put in through the axillary artery. So I think trying to do a mechanical assist short of a balloon pump if they need it or an Impella, I think is just a bridge too far. The other thing is those patients, it was talked about, how do you know when it's too long? And I think, one of the things we always look at is, does the patient have a recoverable injury? Can they recover from their respiratory failure? The trauma patient, you don't always know, right? You don't know how sick they're going to be. So I think our tendency is to put them on thinking most of these folks are young. They should recover. How long is too long? I don't know the answer to that. In terms of the patients that have pneumonectomies, again, a right heart assist would be ideal. But again, that's going to be you're going to have to centrally cannulate them. It's kind of a much bigger deal than putting them on VV.
Question about that, Jim. Just why would VA not be preferable just to offload the left heart, which will help your right heart?
Yeah,
I mean, obviously central cannulation would be ideal, but
yeah,
why VV, not VA?
I think the thing that let me back up. I think most of the patients that are going to wind up at the pneumonectomy, majority of them are going to have a blunt injury. We have few that have had penetrating injury. Many of them have a blunt injury. So the contralateral lung has also been injured. So to actually put them on lung rest and just not have any driving pressures, I think helps the right ventricle. And I think to put them on VA, you're getting back into some of the problems that Bill talked about with the anticoagulation, Harlequin syndrome. If you centrally cannulate them, you avoid the Harlequin, but then again, they're centrally cannulated.
Yeah, would you make a comment on VPA support for post-pneumonectomy? We just had a patient in Detroit, gunshot wound to the chest, pneumonectomy emergently, big air leak, and VPA was utilized, worked great.
How long was the patient on?
About 3 weeks.
Can I ask an ignorant question? What is VPA?
Protect Duo, Spectrum.
Okay.
Yeah.
no.
So the pulmonary
Okay.
artery.
Right.
Yeah.
Thank you.
We don't have.
Good RV support.
Yeah, I mean, I think that, again, the ideal support is anything that's going to decompress the RV and support it, right? I just don't have any experience with that. And also, I think, as mentioned, our experience with the two-stage cannula is not as good as other centers. We still pretty much do, IJ Fem is kind of the preferred approach.
I'll ask one more question. Is traumatic brain injury a contraindication to ECMO?
Look who I'm talking to. What am I going to say? Oh, yeah. No, not at all. Boy, talk about getting set up. No, not at all.
I mean, people
No,
say that
no, it's
all
not.
the
And I
time.
think the reason is a couple of things. I think we've learned that you can take those patients that have a traumatic brain injury, and there's small studies, one of them out of our institution, that said you can run them at a much lower PTT level, 45, 55, with no increase in their, no progression of their neurologic dysfunction. You can also run them completely off anticoagulation, as long as you keep the flow rates. Again, my level is around 4 liters. It drops down around 3.5. I get a little twitchy. High flows without anticoagulation, VV. It's a different story in VA. Thanks for setting me up.
Anytime. All right, thank you, Jim.
Sure.
So next speaker up again, Dr. Lena Napolitano. She's going to talk about update on ECMO in COVID, bicable versus right heart support.
Yeah, so I'm going to talk about VPA
Thank you.
support.
I'm so glad.
And this question came up also all the time. We had some patients transfer to us during COVID with PA support in that we had to figure out what to do. And many of us asked the question, should we be using it? So first, the question we have to ask ourselves is, what's the incidence of RV dysfunction in ARDS, just in general? So in general, most of the studies show it's pretty high, and you do worse when you have RV dysfunction. The largest study is over there on the right, 752 patients, and in general, in ARDS, 22 to 25% will have RV dysfunction. That's a lot. The most recent meta-analysis of, as you can see there, 7 studies, the odds ratio of mortality was about 1.5 higher with RV dysfunction and ARDS. That doesn't tell us anything about COVID ARDS. So what do we know about COVID ARDS? Actually, the incidence of RV dysfunction in COVID ARDS is much higher. So this study from Italy on the right, a small study, showed a 42% incidence of RV dysfunction in COVID ARDS. We saw the same thing, a much higher rate of RV dysfunction and RV failure. And then a study from the University of Minnesota on the left, again, small numbers, but showed that of the patients who died with COVID ARDS, virtually all of them had RV failure. So it brings up the question of what we should do for these patients. So one of the problems is that we don't have a clear definition for RV dysfunction and RV failure in ARDS, whether it's COVID or not. This study has actually recategorized RV dysfunction into class 1, no RV dysfunction, mortality rate 22%. Class 2, there is RV dilation, but preserved systolic function, higher rate of mortality, 42%, and then finally RV dilation with systolic impairment, 73% mortality, very high. They've then put onto this these algorithms with massive treatment algorithms for all these different stages and different phenotypes. Not going to go through this at all, but it's become very complicated of, do we keep them on VV ECMO, add medical management of RV failure? Do we transition them to VPA support? Do we transition them to VA ECMO? It's all become very complicated now. So what do we know? The ELSO guidelines currently say that if you have somebody who just has ARDS without RV dysfunction, you should just use regular VV ECMO, far left. In the middle there, if they do have RV dysfunction, you should consider RV support. And what's easiest to do is VPA support. So veno-venous ECMO with pulmonary artery inflow. So it means pretty much every patient who has COVID ARDS gets a TTE, and we do them serially to follow their RV dysfunction. And then you have to make a decision of how you're going to cannulate them, whether they do or do not have RV dysfunction. But along with that, you also have to assess their stability. So on the far left, patients unstable gets 2-site cannula, right IJ, right femoral. On the right there, you see an Avalon, 32 Avalon put in, and a young guy who had COVID ARDS. We had time to go to the operating room for fluoro. And then this is my dreaded case here, a young woman. We put a 32 French crescent in. She came to us with COVID ARDS. She had no RV dysfunction, and 2 weeks later, severe RV failure, and she died, even despite us transitioning. So this is a real struggle. So the crux of the question is, should we be using V-PA or Protect Duo support early on, because we can't predict who will or will not go into RV dysfunction. So here's the Protect Duo. It is a 2-stage cannula. You see the distal part is quite a bit smaller that goes into the pulmonary artery. It's really easy to manage because it's a single right IJ site. The cannulation is a little tricky. You have to go put a PA catheter in, then you put a super stiff Amplatz guide wire in, and then you put a rail over with your 32 French Protect Duo. It's a little dicey. First report was in 2016 of use of this catheter, the Protect Duo, in a patient who had ILD, and she was transitioned to a lung transplant. And now it's become pretty commonplace, and there is an additional cannula that is available to us. This is called the Quantum Spectrum cannula. It's again another V-pulmonary artery support dual stage cannula. So here's the cannulas you have available. You have an Avalon and a Crescent that are just VV, and then you have a Protect Duo and a Spectrum. So what do we know? Again, the trial, not really a trial, just a report from the Chicago group, the Chicago protocol, 85% survival. Everybody got a Protect Duo. But is it the Protect Duo that's causing the high survival, or is it awake, extubated, ambulating? And so lots of pictures of these patients walking around, doing great. Only about 2% got trachs. They're doing wonderfully. Clearly, their overall series, about 150 patients, also supported about an 85% survival. And then the Milwaukee group recapitulated that. They had an 85% survival with Protect Duo in every COVID ARDS patient. But you have to be mindful that many of us start out without it, and then the patients get RV failure in the end, and unfortunately go on to get some other strategy. So this works, this catheter works, but there are other ways to manage it, actually, that we were just talking about in terms of medications. And our approach has been not to put it in everyone and to personalize the care of the COVID ARDS patients and watch carefully for RV dysfunction and failure, and transition to VPA support or VA ECMO support as needed. So I think it's a controversial issue. I'd love to hear what other people think.
Great, thank you.
Question, Dr. Moore?
I certainly don't have any experience to enlighten that, but I am curious how you manage coagulation in COVID patients. As you know, of course, they have a very dynamic coagulation system, and typically early they are hypercoagulable and get microvascular, and that's probably the reason for their RV failure. On the other hand, within 24 hours, they can convert to a profoundly hypocoagulable state. So how do you manage anticoagulation, and how do you monitor it?
Yeah, I'll tell you what we do and what I'd like to do. I would love to switch to bivalirudin. I mean, there's a lot of data now that it's a safer DTI approach, and it has both less bleeding and less clotting of the circuit. But it's expensive, and so we have not yet switched. We are still on heparin. For the first 2 days, we co-measure PTT and 10As, because when patients have discordant PTTs and 10As, one is higher than the other, that's a problem for increased bleeding. And that tells you they have some baseline coagulopathy, and then we'll do a ROTEM. But we use heparin, and normally we do low, 40 to 50, so very low. And we only go up if we start to see clot. We actually had one young woman come to us with a Protect Duo in place. About 2 days after she came to us, the tip of her Protect Duo clotted. And we were on full anticoagulation. So you're right, some of them are more prothrombotic than others. And we had to retrieve the clot and flush the catheter, and she did fine. Yeah. Complicated. I think it's complicated. I think bivalirudin is the answer. Anybody here using bivalirudin? Not yet. A lot of
Yeah,
institutions
switched.
have switched over. Yeah. DTI is better, more secure, really less bleeding and less coagulation.
And bivalirudin over argatroban? Any reason?
Correct. Yeah.
Interesting. Okay.
Yep. Pittsburgh did a great study looking at their experience with heparin, circuit clotting and bleeding complications, switched over to bivalirudin, both went way down. Yeah.
Interesting. What is your feeling of VPA? Obviously, I don't know anything about it. I made that very clear.
Yeah.
But you're used in patients that have severe respiratory failure, non-COVID related.
Yeah, it's the same thing. We've really gotten into the tact of doing serial TTEs, and if they develop RV dysfunction, then we move to it. It is tricky to recannulate, right? Especially if I put in a crescent. We tend to use crescents rather than Avalons. So we put in a crescent. Now I've got a crescent up here, but I need that site for the VPA. So we actually have to go fem-fem.
Okay.
We do this in IR. So we go fem-fem, and then we release this site. We just put a sheath up there, and then we switch out to a VPA. And we have the Spectrum on site now because the Protect Duo has this funny thing where you have to purchase both the pump and the cannula. Spectrum, you can purchase the cannula separately.
And I assume there's an algorithm that you use with respect to medical therapy for their
Medical
right heart
therapy
dysfunction
first. Yeah, so
before.
that young woman I showed on the right in my last talk, a young pregnant woman, she developed RV dysfunction. We actually managed her with INO and milrinone, and she never needed a recannulation, and her lungs were getting better, and then we got her weaned off. So I don't feel strongly that one approach is better than the other. I really think you need to personalize this care. If they respond to medical management, that's great.
Great.
So, Lena, this
Yeah.
is clearly outside my wheelhouse. I mean, I don't anticipate we're going to be doing this pre-hospital. So,
Yeah,
but,
I don't think so. It's
but
hard to put in.
I'm interested when you say you don't want to necessarily go to VPA immediately and all this. You're going to wait and watch some of them, and then when you see signs of RV failure, you then. But I would take you. Where's your decision point? Do you start early? Any first signs of RV failure? You do it early. You want to try it early.
Yeah, you know what we see early because clearly we were doing weekly TTEs and we were doing them ourselves as well, just doing a bedside POCUS, right? But what we see is hepatic congestion first. You'll see the LFTs start to go up and you'll see a little bit of AKI. And you see that, that's RV failure. And once you see that, go quick. We start medical management and then we try to go to IR pretty quick to change out. I think we're going to see this in the future, but it is a strategy that can only be done in-house. Yeah.
Impressive.
All right. Thank you.
Thank you so much. Next up, we have Dr. KJ Nagershev. He's going to be talking to us about percutaneous mechanical thrombectomy as an adjunct to PE treatment while on ECMO.
Thank you. Good morning. Thank you to the Society and to Dr. Fox and Cundy for the invitation. The title is a little bit misleading because there's probably about 12 papers on this out there. And so there's going to be some data that I talk about in this, but it's going to be a lot on PE more than the ECMO part of it. So we'll go through some background definitions, some risk stratification for these patients, some of the literature on percutaneous PE treatment, and the literature on ECMO and PE, and then we'll have some concluding thoughts. So in terms of stratification of these patients and some definitions, PEs, we stratify them into minor or non-massive, submassive, and massive PEs. The distinction here is right ventricular dysfunction as defined by an RV-LV ratio of 0.9 or greater, as well as chemical identifiers of myocardial necrosis. If they have hemodynamic instability or collapse with a systolic pressure less than 90 for greater than 15 minutes, they're classified as massive PEs. They can also have significant bradycardia as well. This is sort of the breakdown when you look at this nationally and internationally in terms of the PEs that occur. Submassives account for about 40%, minors are 55%, and massives are only 5% of the PE population, which is good because they have the worst outcome overall. In terms of massives, their in-hospital mortality has been reported to be about 25%, and the 90-day mortality for massives is 50% or higher, depending on who you read. So overall, this has not changed over the last 15 years. There's a ton of papers out there looking at PE registries and PEs overall saying that RV-LV ratio greater than 0.9 has bad outcomes. Higher mortality, 6.6% in this one, 17% here, and adverse event outcomes of 80% or higher, meaning all adverse events, not just mortality. We classify things based on BOVA scoring. This is kind of an antiquated approach. In fact, the European Society has put out a more up-to-date, more comprehensive scoring for PE criteria for PE as well, but this is kind of what we use here. We have a fairly robust PERT program here with over 270 activations a year for submassive and massive. This is what we are using currently. So low risk stable, these patients are identified on CT scan or VQ scans. They have really no right ventricular dysfunction, no hemodynamic instability. They're fine to be treated with anticoagulation. Submassive stables with low risk of bleeding. These patients have evidence of RV dysfunction. They have a low risk of intracranial bleeding, or so they could be theoretically treated with systemic thrombolytics if needed. The high risk patients should not be treated with systemic thrombolytics. And massive unstable, these are patients with severe hemodynamic collapse, as we've talked about, usually have cardiac arrest on presentation and will need some sort of advanced therapy, surgery, or percutaneous or systemic. The problem with lytics is there is a 20% risk of major bleeding and a 3% risk of intracranial bleeding, so we try to reserve this for only certain situations now. So in this kind of slide on the left panel, you see the RV pressure, the systolic pressure at baseline, and then at 6 months in patients that are given TPA plus anticoagulation. On the right side, their RV pressures are all over the place at 6 months if they were treated with anticoagulation alone when they come in with submassives. These are some studies that have shown intracranial risk of bleeding about 3%, 2%, depending on who you read. This busy slide here, it basically shows 13 placebo-controlled, randomized controlled trials looking at anticoagulation or placebo versus that and TPA, and a total basically of 800 patients overall have been randomized into these trials. There's very little good data out there on PE treatment. The ULTIMA trial, industry sponsored, looking at ECOS catheters. I'm sure everyone's seen ECOS. It's ultrasound accelerated administration of TPA. But again, industry sponsored. Their criteria were patients with symptoms less than 14 days, no hemodynamic instability, no active bleeding, symptoms of PE plus CT findings, and they took them within 24 hours. And so they had a higher ICU stay, they had longer length of hospitalization. The RV-LV ratio at 90 days is really no different between ECOS versus treatment with heparin alone. And if you look at the overall rate of major bleeding, 20%, intracranial hemorrhage about 3%, like we talked about, versus none for catheter-directed. When you look at the ECMO literature, the use of ECMO as a standalone therapy has been advocated by a lot of authors, but it's still controversial. The European guidelines say to use ECMO may be considered in combination with surgical embolectomy or catheter-directed treatments for refractory circulatory collapse or cardiac arrest. There's no RCTs that address this and no RCTs that really look at this time. The physiologic rationale makes sense. A VA ECMO is one of the quickest ways to really restore hemodynamic stability for these patients and provide adequate gas exchange. It's efficient in supporting the RV. RV is offloaded, and the subsequent decrease in end diastolic volume, end diastolic pressure, and myocardial oxygen demand helps the patients, and it increases coronary perfusion as well. The survival advantage is that the existing data is really single center studies, small samples, can't really say there's a survival advantage just yet. These are 4 studies that have looked at the use of ECMO and anticoagulation as standalone therapy. Mortality rates are still quite poor, anywhere from 60% to 38%, depending on who you read. When you look at the data on catheter-directed therapies in ECMO, the data is scarce. There's really 3 studies out there with only 36 patients, and they still showed a 25% mortality. So you really need further data. There have been studies that showed that catheter-directed TPA versus systemic lysis, really no difference. Actually, catheter-directeds have a higher rate of minor bleeding as well. Keep moving. These are 3 cases we've done here on ECMO. You get a significant amount of clot out. The time on ECMO decreases a lot, and they do pretty well overall. And you can see the case 3, the white stuff, that's collagenized clot. That's been there longer. And so I can go through kind of what happens with the anticoagulation and ECMO and these clots, but that's also a very interesting thing we found. 25% reduction with just suction thrombectomy on ECMO and off ECMO, and no need for TPA, decrease ICU length of stay, decrease utilization of resources overall. And in conclusion, acute central and subsegmental PEs with signs of hemodynamic and chemical compromise, you can consider CDT. CDT with lysis carries a significant cost and risk to the patient. All need ICU care. Although TPA can be used now, other thrombolytic therapies other than thrombolytics could be considered and should be considered first. And if the patient's already going to be put on ECMO for PE, it actually makes taking out the clot easier. So with that, I'll take any questions. Thank you.
Questions from the audience? So what's your algorithm now for a patient who's high-risk bleeding? Obviously, patients low-risk bleeding is going to get systemic TPA in the setting of either submassive or certainly massive.
Sure.
What's your algorithm for high-risk patients?
So high-risk patients, I think, are a good candidate for thrombectomy. If they have a submassive or if they have a massive, for sure. But if they have a submassive, I think they're a good candidate for thrombectomy. Our algorithm here is if they show signs of hemodynamic collapse, they start having micropunctures put in, they get put on ECMO. And the algorithm at the university is to keep them on for a minimum of 5 days. I think that's a huge resource suck. I mean, keeping these patients on ECMO for a minimum of 5 days when in reality they're on for like 9 or 10. And you have a hard time getting them off. But what we find is when you try to suck the clot out in these patients that have had symptoms for like a week or 2 weeks, it's actually challenging because it's collagenized, it's stuck in the PA and all the segments. But when they're on ECMO, you get disturbances in von Willebrand factor, you get disturbances in consumptions of procoagulants and anticoagulants, you get disturbances in antithrombin. So it's actually much easier to pull this out. It makes this clot stickier, for lack of a better term, and pulls it out easier than the organized stuff.
So just to clarify, so ECMO and then catheter thrombectomy?
Yeah,
For high-risk
yeah, as
patients?
opposed to lysis.
Questions? I'm curious, for those patients that need to go on ECMO, say massive or submassive, they're unstable, and you put them on ECMO, and then you do catheter-directed therapy, how long after you've removed the clot are they likely to require VA support? I mean,
Yeah,
would they
so
come
that's
off really
actually a
quickly?
great question, right? There's no good data on this. I actually just wrote a trial on this, trying to get it through. But what we're seeing is they're coming off ECMO within 2 to 3 days, as opposed to keeping it on for like 9 days, 7 days, a week, 2 weeks.
Kind of a technical question, KJ, but what wire do you use when you do the clot retriever to get through the RV?
Yeah. So I start with a Benson wire and an angle pigtail. It gets me up there. The angle pigtail you can actually pass without a wire, and you can just flip it right into the PA. And then once I get into I start in the right PA. Once I get into the right PA, kind of lower lobe, I put a 1 centimeter stiff Amplex. And the clot retrievers, you just got to be careful with where your wire placement is, right? You don't want to use a glide wire. That's easy to perforate the PA with a glide wire. So then you take the 26 French or 30 French device straight up from a femoral approach, and it's very flexible. It gets up there very easily.
And do you find it challenging to maneuver past the cannula?
Not really. So with the ECMO, hopefully their cannula on the left, that makes it easier. But if they're cannula on the right, it's a little more challenging because you got the extra curve and you got to go under the iliac artery. But no, it's not been really hard. But if you do have trouble getting a wire through, then I recommend putting a balloon and pulling back so you make sure you're not behind a chordae and you don't rupture anything putting this thing up.
And what's your endpoint when you do this? When do you decide that you've taken enough clot?
So I just go for pressures. And so I look at my pressure to start, and I make sure I have at least a 10-point drop.
Okay, thank you.
KJ, what do you do with patients who literally cannot be anticoagulated? Is there a role? Can you do thrombectomy without systemic heparin?
Yeah, you just keep flushing the side port with heparinized saline.
Okay, so I'm going to call you next time, not somebody else. 'Cause
Oh, sure.
They're going to tell me they can't do it unless the patient can be heparinized.
Yeah, no, we definitely do it without heparin.
Everybody know, call KJ.
Thank you, guys.
Thank you. All right, well, we're moving on to our panel discussion. A little hard to do without having seats for people, but if people would come up to the microphone ask any questions you have. I would like to take the privilege of the podium to ask Dr. Manning to comment a little bit, given his expertise on pre-hospital use of extracorporeal devices, if you don't mind. Not to put you too much on the spot.
Oh, well, sure. I guess, well, there's clearly movement steadily more toward using extracorporeal circulation in the pre-hospital care setting. Most of that's happening in international locations such as Paris, and I think there are at least five cities in France that now actually have pre-hospital VA ECMO programs, and the results are actually quite impressive. Fundamentally, what they found is if you're dispatched to the scene of a cardiac arrest, and you can get to them, put them on VA ECMO within 1 hour of the onset of the cardiac arrest, provided they've gotten their witness arrest, had good CPR, other things have been done well up to that point. If they can get to them and put them on VA ECMO in under 60 minutes, survival rates are pushing 30, 40, 50%. And some of the work, if any of you are aware of what's going on in Minneapolis, they now actually have Dimitri Yiannopoulos has got a truck, a mobile cardiac cath lab, and they actually mobilize out to the scene, meet paramedics, put them in the back of this truck, put them on VA ECMO, and then do PCI right there in the back of the truck. And the survival rates they have early on, even for those that are getting taken to the hospital and going to a cath lab immediately, are pushing 50% for cardiac arrest. Now, if you haven't spent your life studying cardiac arrest like me, when you start talking about 30% survival and 50% survival, these are massive jumps over what we've been seeing for the last 50 years. So there are more and more programs, there are more and more places that are actually advancing into pre-hospital ECMO. And I think that's the way the world's going. And I kind of like to see the United States catch up, and we're trying to work toward that actually, here, along with the technique I've worked on for so long time.
What do you see as the big barriers to being able to do that here in the United States?
The biggest barrier in the United States is that we don't have physician-staffed pre-hospital systems the way in many places in Europe and Australia, they have physicians in the field. So they already have the infrastructure in place to train people to do this. We have to build that infrastructure, but I think that's where we're headed. I think that's what we should be doing, and that's one of the things I'm working on.
Is this something that can be done by non-physicians in the field? Can we train our paramedics up? And I'd love other people's thoughts on this, because this is super controversial. I know.
I would just say someday in the future, but it's like evolution. It's a stepwise process. We're not going to put this in the hands of paramedics to begin with. I think we have to build systems that have physicians. If we get to the point where we really got a lot of it automated, including the vascular access component, which is a big first step, it may be possible that we can take advanced practice paramedics or somewhere between paramedics and physicians and train them and have them do it in the field. Potential.
I would love to hear some thoughts from some of the people who've been taking care of patients for a long time. I don't know, Doctor, I hate to put other people on the spot about this particular issue, but I just find it fascinating. And as you said, Jim, the differences in mortality, neurologically intact survival is just, hugely dramatic. But it is a huge resource. Anybody have thoughts on, should we train a bunch of paramedics to do VA ECMO in the field? I'm just out of curiosity. It's.
I'm thinking about.
No, please.
I'm thinking about New York, and for example, 40 years ago we made trauma BLS 1, meaning scooping runs of the hospital. And I'm thinking about the level of training of paramedics in our city, right? So when we think about it, it's difficult enough. So I've got one of your fellows, right? Anna Lavera, who helped start an ECMO program for us at New York City Health and Hospitals. She has trouble sometimes cannulating people, right? She's a shock trauma trained fellow. I just don't think, and it's what Dr. Manning said, right? So I've been over in Europe and hanging with British and those guys. It's a very different system, right? They're doing thoracotomies off the helicopter, right? It's a completely different mindset than what we have. And in this century, I don't see trained paramedics in New York. It's just me. And I've been wrong. Tom brought me over. It was kind enough to invite me 10 years ago. I saw you guys doing the ECMO, and I'm like, why are surgeons doing ECMO? So maybe I'm not the guy with the vision.
Yeah, please.
Graham Nickel from Seattle. I have industry funding related to some of these technologies. I think it's important to understand and appreciate that a paramedic is not a paramedic. just like a surgeon is not a surgeon. There's a wide variation in the degree of training and the skill set of paramedics around the country. Do I think paramedics are going to start doing ECMO in the field tomorrow? No. But I think as vascular access becomes simpler, it may be an option in selected communities.
Do you still have your program in Seattle? I know you guys were doing, I know I talked to Dr. Bulger about this. They were doing some pre-hospital ECPR program. I think it was a pilot program. You may not know. I'm sorry. I don't mean to put you on the spot.
I think that would, the short response is no, we are not doing ECPR in the field. We did try at Harborview to implement ECPR in patients with refractory cardiac arrest. It was a bust. I think for not so much technical reasons, but implementation issues, training and experience, and the people initiating the ECMO were not the people who were available at the door, is a somewhat carefully worded analytic comment.
Very, very politically correct. I might add.
I think it's complicated, both in the ED and in the field. It does require interested people who are available. It does require people who are highly proficient and who do it a lot. I don't think that is going to apply to every community, but I think it may apply in some communities. I think it also probably requires some device evolution to make it simpler.
Thank you. Is anybody aware of any, please, going up, any technology on the horizon that will make the access aspect of this easier? Because that, I mean, as Dr. Tupperman said, that seems to be the rate limiting factor for a lot of placement of these devices is the ability to access. Anybody aware of any?
There are a number of groups, actually some funded by the Department of Defense, that are actually working on devices to make it more automated using AI and stuff. I was actually just visiting one of them at the Lincoln Labs at MIT last week. So there are people who are actively working on this to try to make it much easier, not just potentially out in paramedics, but for making it easier for people like us who do this a lot. But if those technologies evolve sufficiently, it may be possible that those could be put into the hands of intermediates.
Yeah.
I have a question for everyone, and that is, we're talking about putting patients on ECMO with unclear neurologic status. And, in the heat of the moment, you don't have time to assess, they're young. How does the patient being on ECMO change your approach to assessing neurologic status, specifically brain death testing? How do you decide to withdraw ECMO when the patient's family says they're alive? Why would you do that? And also, what do you do with the patient who is on ECMO and their neurological status becomes clear over time, and as it becomes clear, you realize that this patient is not going to recover?
Are you asking me that? Looks like you're looking at me. I'll offer my opinion, but I would really welcome anybody to come up and give theirs. I mean, I think the evaluation for neurologic prognostication is extremely complicated, and ECMO, yes, further complicates that. But I don't think it precludes your ability to evaluate somebody's neurologic status. Death by neurologic criteria or brain death is a clinical diagnosis. That the ECMO doesn't change that. In fact, we actually have a protocol to do apnea testing on ECMO. You can do it. You just basically turn off the sweep, or you turn down the sweep as low as you can go, and you allow them to retain CO2. So from an overall prognostication, I don't think it actually changes things. I think your ability to declare death by neurologic criteria is made a little bit more complicated, but certainly not, you're certainly able to do it. The issue about poor neurologic outcome and prognostication, that somebody is going to do poorly, is a very personal thing to an individual patient. And this is my philosophy on prognostication following brain injury overall, is that this is about what the patient would want for themselves with respect to overall functional outcome. And that's not something that we as healthcare providers we don't make recommendations. We make our best medical guesses about how people are or are not going to do. And I don't think ECMO changes that ability. It does make it a little bit more difficult. So would love other opinions.
I just wanted to make a quick comment about prolonged field care and forward care in the military, because there are organizations that are looking at like telehealth and robotics to train people on the forward edge of the battlefield. I just recently got trained on one called Teledoc. And it was really impressive, like the resolution that you could get from that robotic instrument. And I know Gene and I in Denver were training people how to do access through a course that we were doing at the University of Colorado. And it is really challenging to teach people who aren't having the opportunity to access femoral vessels all the time. But it sort of rejuvenated my interest because at the MHSRS meeting in Orlando this year, there's a lot of DoD funding that's being allocated for training people in a forward environment and teaching people that are non-physicians. So it might be worth looking at it if you have a research interest in that area.
Great, thank you.
So just taking a step back for a moment, but on the same topic, who and where should we be doing ECMO? So, I mentioned that, 10 years ago, this was a wow here that you guys had, created a whole wing for doing this. But in my mind, and my hat on as the chief trauma surgeon for New York City Health and Hospitals, right, the largest public hospital system in the nation, I was like, this is a university hospital thing. This is a Tom and Deb thing. This is not a Sheldon thing. And then COVID hit, right? And then I was on the phone to you guys. You guys were trying to help us. And so the question is going to be, should safety net systems take this on? So I'll just say that right now in my system, Bellevue and Jacobi are doing it. And when Tom said to me, you got to have people that are trained and you have to have enough experience. But given what we went through and you guys did try to help us, but the begging and the phone calls and the turndowns, I do think it is time for safety net systems that can do it judiciously with well-trained people. It's time for it to have the availability in certain locations. I'm wondering what other people think.
Yeah, great question. Other thoughts? So sort of a regionalization approach, an ECMO center designation?
Right. I mean, in the past, we all said this had to be a quaternary referral thing, but that certainly didn't work during COVID. And the machines, as Dr. Connor's talking about, are much better, much simpler to use.
Just going to make a comment.
Please.
Jeff Lawson here. So our technology has evolved way ahead of our ethics. And so it's, in the 70s, we figured out how to do dialysis, or the 60s and the 70s. And we couldn't let kidney patients die. And so now your kidneys can die, and with ECMO and some of the other technologies, your heart can die, your lungs can die. And I think the diagnosis of death has become incredibly challenging because we can do amazing things. And there's a part of it is, should we and when should we stop? Because now sometimes you can't stop. You can't take people off dialysis unless they consent to do it. And I don't know what you do with some of these ECMO patients. So anyway, sorry, just a comment.
If that is, it's a great comment and a great question. Dr. Slam?
Yeah, I'm going to push back a little bit at you, Shel, because we did that. We regionalized this for COVID. We had University of Maryland. We have 14 hospitals, and I take a little credit for this, set up a system where we didn't bring every sick person downtown. We spread them out over the community ICUs. It turned out that those guys in the community were pretty good, and we could coach them. And that allowed us to have beds downtown to put all those people on ECMO. And so it is a doable thing. It does require organization. It requires somebody at the top to drive it. It requires somebody answering the phone 24 hours a day, 7 days a week, saying, no, you're okay. We won't go away. You can call back. And I think if you can get that degree of cooperation in your region, you can set this up. And we're not there, but we are dragging everybody else kicking and screaming to try to get to that.
Next, Dr. Moore?
Just to follow up on the declaration of fetal care with a traumatic brain injury, this is really, as you all know, the impediment to retrieving organs around this country. DCD in trauma patients with fetal care is, I think, the biggest challenge we face in providing a resource to the community. We're wasting organs in every trauma center every night. We use a combination of sequential CT scans and ICP monitoring with our neurosurgeons. Bihemispheric lesions with ICPs approaching diastolic pressure, they acknowledge. And we have now done DCD with brain injured patients with organ retrieval. But I think that's a challenge we all need to confront. I know we're into this ethical issue, as Jeff Lawson said, but I think as a society, we need to confront this and retrieve these organs from patients who have fetal care for brain injury.
I could, yeah, I think that that's worthy of a lot of discussion. I think that our ability to prognosticate still is quite poor, and futility when we talk about absence of intracerebral flow is one thing, but just very, very poor neurologic outcome is not necessarily futility. And I think we just have to be careful about the semantics of that. But I totally agree with you. The number of patients for whom we are able to successfully get organs for successful donation is way too low for the number of patients for whom we do ultimately withdraw life-sustaining therapy. Couldn't agree more. Thank you all very much. Yeah, thank you.
Breakfast being served in the other room. If anybody wants that, we have a 20-minute break.